Welcome, everyone. How's everyone doing? Good. All right. So this is exciting. I mean, this is an important topic, trust in healthcare. And we've got a great panel here. So I just wanted to highlight, I'm the president and CEO of the National Association of Community Health Centers, which represents the largest primary care system in the country. And of course, trust in communities is incredibly essential. So this program is about transformative health leaders, but clinician leaders typically. And so we've got a great panel here. So I'd love to start with letting people introduce themselves, and especially on this topic of trust. So Dr. Copeland.
Okay, hi. My name is Laura Copeland, and I started my career as an American board certified emergency physician, working at the Cleveland Clinic. And that was when I was tapped on the shoulder and asked to participate in their health information system implementation. That was like 20 years ago. And I think that they probably should have tapped me on the shoulder and said, how would you like a second specialty? And then why don't you just keep going with that first one as well, so you like have two jobs and two things to worry about. But no, they didn't tell me that. It was a big surprise. And the other thing that was a really big surprise for me was that my first son was born with severe hemophilia. That was a big surprise. And that was my first experience of losing trust in the health system, because he wasn't but 6 weeks old and I was already facing pre-existing condition clauses and trying to find somebody to take care of him so that I could go back to work, and liability issues were a big problem. And then kind of calculating out how many years I had until lifetime maximums were met. So access, even as an emergency physician at the Cleveland Clinic, was a real issue. So I made a decision to go back to Canada. And I'm not advocating for everybody who's having access issues to move to Canada, just to be clear. We do have access issues in Canada as well. It isn't because people don't have access to socialized medicine, but there are many, many barriers to access. And so I think access is one of the important conversations to have around trust in healthcare. And when you don't have access, you end up in the emergency department, which is where I worked for 10 years. And long enough to feel very, very anxious when a patient would come in and that HIE button was there in my record. And I think I want to rename it. It's the provider hypertension button. Right? Because you know that if you push that button, your blood pressure is going to go through the roof, because suddenly you have a 2,000-piece puzzle that you have to put together in 2 minutes and counting, and forget your relationship with your patient. So after doing that for a decade, I said, hey, I need to make a change. And I did two things. One, I changed my entire practice. I reskilled, and I became a medical psychotherapist, which is a very unique thing in Canada. It's primary care mental health. I now work in a community family practice, interdisciplinary family practice, and I see patients doing psychotherapy. So I have a relationship with my patients again, and I guess that's like my second big thing about trust. It's really great to have the time to have a conversation with your patient and understand what's important to them. And the other thing I did is I really dove into that informatics, and I worked for 9 years at Humber River Hospital, helping them go from a predominantly paper-based hospital into what at the time, when they went live, was North America's first fully digital hospital. So a lot of technology coming together to help that provider-patient relationship. So I also then jumped off and joined Nordic so that I could spread some of that good intention and focus on provider needs and health information system function around the world at this point. So 3 things that I think are important for trust in my history there: talk about access, have good relationships, and IT alone doesn't solve your problems, but with good intentions and with all the stakeholders at the table, it can. So that's my intro.
Thank you.
Yeah. Hey, we don't have to pass mics.
That's great. Thank you, Dr. Copeland. Dr. Ho.
Hi, I'm Dorothy Ho. I am the Director of Customer Experience at a company called Impact Care. And I'll tell you a little bit first about Impact Care and what we do and kind of how I got there and what I've learned about trust along the way. So Impact Care is the nation's largest evidence-backed community health worker intervention program. And Impact Care just actually spun out of the University of Pennsylvania last summer to really build and scale what had been developed at UPenn over the last decade or so in terms of defining what makes a successful community health worker program. Like, who are these people? What do they do? How do you manage them? What are the outcomes? Because of the success at Penn and the success in sort of training other programs, we've spun out to both develop the software that will support community health workers and help other organizations who are interested in building and scaling their own community health worker programs to help them really get trained, get up to speed, and start their own program. So that's what Impact Care does. My role there is we're early, so it's a lot of things, dishwasher, cook, waiter, but I both work with the product team and I also work on the implementation side with our software. And so that's a little bit about what I do now. My path there has been a pretty long and kind of circuitous one. I started my career in medicine. I was training as a neurosurgeon, but had always been interested in the bigger systemic questions and in problems in healthcare. And so I left and spent about 3 years working at McKinsey & Company, consulting with big plans and health systems. And then from there, sort of slowly worked my way over to the innovation, design, and product worlds. Where I kind of live now. And I will say through that whole journey, my perspective really changed from trust, as a clinician, thinking that this is something that I was maybe somewhat entitled to, thinking we work so hard, we train so long, we go through a lot for the sake of the people that we're taking care of, and we deeply care about them, thinking that, why wouldn't you trust me? To really having much more of a user or patient sort of centered view on trust and really understanding that, that's not sufficient, right? In terms of when you see a patient, you see a client, they're really looking at you as, do you understand me? Do you hear what I'm saying? Do you value what I value? And only if those things are true should I actually value what you're telling me. And I think that sort of perspective is one of the things that drew me to where I am now with Impact Care, which is Impact Care's model of community health workers is to really, hire the right kinds of people, so people that are from the community who have the same lived experience as the clients they're working with. And also to really kind of put clients, we call them clients, you can think of them as patients in other settings, but really put clients in the driver's seat. So if somebody qualifies for community health worker support, to say, all right, you've got a community health worker who is here to support you for the next 3 to 6 months oftentimes. And the community health worker's job is to really say as a person, as a client, what do you value? We're going to have the next 3 months together. What is going to make the biggest difference to you in getting your life and your health to a better place? And sometimes it's medically related. Sometimes it's about maybe quitting smoking or changing their diet, but lots of times it's relationally driven. It's about mending broken relationships. It's about being more connected to other people in their community. And the really magical thing is that it works. It almost sounds too good to be true that actually letting people take the lead on what they need most really works. And the impact intervention has had multiple randomized controlled trials that demonstrates decreased length of stay, decreased total cost of care, decreased readmissions, things like that. All your classic kind of healthcare indicators, just by putting people in the driver's seat and really trusting what they say and supporting them in what they need.
Great. Thank you, Dr. Ho. Teresa.
Hi, everybody. Teresa Meadows. I'm the Chief Digital and Information Officer for Cook Children's in Fort Worth, Texas. Cook Children's is an integrated delivery system. And the nice thing about that is that we have our 2 hospitals, but we also have a very large physician network. We employ about 500 physicians in all specialties, so primary care, specialty care, urgent care. We do home health, so we have a very large presence in home health across the state of Texas. And then we also run a Medicaid health plan. So Medicaid and CHIP, we have about 150,000 members in our health plan, and that allows us to have a unique point of view across all facets of someone's care, whether they're an inpatient, through an ambulatory visit, or even just through care management through our health plan. And so I've spent many years in healthcare IT, but I started my career as a nurse, interventional cardiology, cardiac transplant. Very much like Laura, we were implementing CPOE for the first time, and my nurse manager came to me and said, "Hey, Teresa, you're pretty good with the doctors. Would you like to do this little project where you train and support the physicians doing physician order entry? You'll do that thing for a couple years, and then you'll go back to your nurse. You'll come back to the floor and you'll do the nursing job." What I learned about trust that I didn't really understand at that point in time was what she was saying to me is the physicians trust you. You're very good with the physicians. You have a good relationship with the people that we take care of, and we'd like you to help them learn to trust a computer. We didn't have computers. We didn't have computers on the nursing unit at that time, so it was really the very first time, 900-bed teaching hospital. So it was a very significant experience. And what I learned from that is I really enjoyed figuring out how technology could support the clinical experience. And so from that, I went into consulting. I worked for McKesson. In that role, it was also a trust role, which I didn't realize at the time, but when I look retrospectively, we had clients who purchased a lot of our software but implemented nothing. And my role was to go out and really build the relationship and really figure out, why is it that you would buy clinical documentation but not use it or not implement it? Or what are the reasons why you can't move it from this point to this point? And what we found is that we never took the time to really understand what the clinicians did. We handed them software where we thought we understood what they were doing when we didn't. And so my role was really to figure out how to build that trust with them and then learn from them so that we could then make the software better for the things that they needed. And so I think that my role today is really about finding ways to show people how technology can support their clinical work processes. But the first step is to really, you have to know them. And I think the other panelists have said it very well. You have to know where they're coming from, what they work on, and the things that they do, or they're not going to trust that the things that you're trying to implement are going to actually work. And so that I think, maybe I'm a trust broker in my current role, but that's sort of my journey through this path too.
Yeah, I mean, I just want to highlight, so I'm a primary care doc, and I've had the privilege of working in underserved settings as a primary care doc, and now the role that I have, I feel like as a physician leader, we can be trust brokers. Clinician leaders, we can be trust brokers. In fact, if you Google today the front of the New York Times, there's an article where the health centers are covered. We serve 1 in 11 Americans. We're right on the front page. My mom called me and said, "You're on the front page of the New York Times." And so we can often be trust brokers and tell the stories that we know about, that we've seen. The title of the story is Medicaid Unwinding and the impact that it has on our healthcare system. But I just want to highlight that capability we have as physician leaders, clinician leaders, to tell stories and be that trust broker, because whether it's journalism or other settings, we've got a huge opportunity to use our voice. There was a reference that I've heard made about the role of technology. So while in many ways we are good at the humanity and what happens in an exam room and building that trust, the role of technology is a tough topic, and how to build trust through the use of technology. So would love popcorn style for you to answer. What do you think are the challenges and the opportunities to use technology to advance trust in healthcare?
Okay. How many times have you gone to your physician's office with some data off of an app and said, "Hey, what does this mean?" And your doctor just goes, "I have no idea." Because I've actually done that myself. And I think helping our providers understand how to use technology, how to use some of these technologies that are very common that patients already have access to. We really need some education. We need some Teresas out there who are going to hold our hands and help us implement new technology and have meaningful conversations with our patients about what is important to them on a technology perspective as well, so that we can meet them there.
Yeah, the other thing that I would add is the technology is not Apple. It's not Amazon. It's not pick your favorite commercial application that you use. Did you have someone who had to show you how to use it and explain how it happens? No. And so our technology today is still not at the level of downloading an app from the App Store. And so we have to create environments where we can actually still provide the training and education that people need to use the technology. So I'll give you an example that we've done. We've created a concept that's called our tech zones, and what we were trying to do is take the burden off of clinicians for training patients on how to use some of the home-based apps. So imagine you're a newly diabetic and you've got your new monitor, your blood glucose monitor, and there's an app with it. We allow our physicians to actually write referral orders to our tech zone, where we have patient advocates who teach the patients, A, how to download the app, A, how to connect the app, A, how to integrate their data into our patient portal. But also then we can circle back with the physician and say, now that the patient has learned how to use the technology, here's how you look at the results that are coming back to you. We don't do a great job of that, and therefore that's why a lot of physicians don't use the latest technology, because there's so many barriers to adoption and lack of use. And so I think we have to think about it differently as we start to deploy more and more of these mobile patient-centered apps, so the doctor isn't caught off guard saying, well, I want to use this thing, how do I use it? And so thinking more creatively about how do we start to bridge that gap between a patient and a physician with the app in the middle as the translator.
And before Dr. Ho goes, on the technology, use the app. If you'd like to ask us a question, go to the session, select Insights program, and submit a question. All right, Dr. Ho.
That was very smooth.
Let's do it earlier.
Speaking of technology, I think I would just echo what both Laura and Teresa said in terms of, I think with technology, what's super exciting as an opportunity is how much it can scale knowledge and how much it can scale things that were originally were complex or really manual. It can make it more seamless, and then it can make it much more accessible to people who have access to the technology. And I think that's where a lot of the challenge with technology lies, is on the flip side of that, which is, yes, it can do those great things if you're tech savvy, if you have the time and willingness and resources to invest in learning all of this. And I think, Teresa, you're exactly right in terms of the big challenge there to help tech deliver on that promise or that opportunity is, how do we really deploy it in a smart way and in a way where we're still really honoring the end user experience and thinking not just about what data does it report, but how does it fit into somebody's workflow? How does it fit into of a clinician for a patient or a user? How does it fit into their life? And how do you actually sort of make that technology accessible and practical, honestly? Otherwise, all that great promise is just never going to come to fruition.
I'll just highlight, there's a term for technology that we use with the community health centers and that I used when I was the chief medical officer at IBM. It was tequity. How do we make sure technology advances health equity as being a key value prop of the role of tech? And so it's a concept that I've thought about, and I think it's so important as you build products and solutions to make sure you meet the needs of advancing health equity. I'm going to ask a question. It's related to something we talked about in the prep around now going back from tech to the people, whether it's patients, whether it's community health workers, members of the team, whether it's issues of diversity. The fact that often trust is about having a population that serves, that represents the people they serve. So would love your comments on that, on those issues. Diversity, team, patient. Popcorn style.
Yeah, I mean, I think you have to understand the population that you serve first. I mean, if you haven't looked at your data and really truly understand the different populations that you're trying to work with, it's really hard to develop a diverse solution that will meet all the needs. So, for example, we built a PEARLS dashboard, and PEARLS is an acronym. It's healthcare, so we have to come up with some acronym. But it really talks about the demographics of that person, the family situation of that person, the ethnicity of that person. And each of the letters, there's a certain data point. And we look at our data for our patient population and our employee population against that PEARLS data. So that way, at least we have a starting point to know. Believe it or not, in Texas, we have a very big Vietnamese population. Most people would have said your number one population is a Spanish-speaking population. Well, number two is Vietnamese. Well, we wouldn't have known that had we not looked at the data. And so trying to find people who can translate medical, like consents into Vietnamese is very hard. And so those are the things that you have to start looking at as you go through your understanding of your populations, because then you'll know you won't spend your time on maybe Spanish or other languages, because you really need to do something different. But it has to start with the data, I think.
Yeah, and I think at a person level too, when we at Impact Care think about how we hire community health workers, a requirement is actually that they have a shared lived experience and a shared sort of community background as the people that they will serve. Like, that's a requirement. Like, one of the things we like to say is, like, I personally could not be a community health worker in like most places, because that's not my I don't have the same shared lived experience. And so I think having that really valuing that shared experience and putting it as something that's just as important as all of your other qualifications, I think has really, at least at Impact, helped us identify those community health workers who are really going to be able to connect and to be able to make a difference in the lives of the people that they work with.
Playing on the notion, the clinician as the broker of trust, I think there's an incredible responsibility for taking a look at our own biases and on a regular basis trying to kind of unravel those biases and figure out where they're coming into play. And we just had a fantastic conversation at the table before we came up here about how when a provider is dealing with patients over and over who are like, no, I don't want to hear about the exercise or the diet, just give me the med for the hypertension. And you hear that day in and day out, and then suddenly, what do you know? You're not even suggesting the exercise and the diet. And how does that skew your entire population data? So bias is so important to keep in mind and unravel on a daily basis.
And I'll just highlight, I think it's so important as the U.S. population becomes, it's now 40% minority, minority health will be majority health by 2042, that we need leaders and populations and providers and team members that represent the people we serve. And at community health centers that serve 1 in 11 Americans today, there's no question, I believe, that diversity is a key component of the trust that we have with the communities that we serve. And that needs to be at all levels. One of the greatest innovations that I think in the healthcare system is the fact that community health centers, they're nonprofits, but they're patient-governed boards. 51% user boards that represent the people they serve. And I do think that that's a key ingredient for trust as well. So as we think about the broader system in the healthcare ecosystem, because many of us come from a perspective as clinicians, but we also know there's challenges with the different dynamics of payers or health plans or the government, state, federal, and this is just in the US, right? There's lots of dynamics of producers of products, industry, pharma. As you look at the challenges of making sure trust exists between patient and provider, but then knowing that the broader US system has all these other stakeholders who play a role in potentially interrupting or improving that trust, what do you think in terms of that broad, fragmented ecosystem? There's the one word I would teach when I taught at the School of Public Health at GW was, if you had one word that represents the US health system, it's fragmentation. And so that fragmentation plays a very important role in sometimes disrupting trust, but also potentially accelerating it. So be curious in terms of your companies, your organizations, what are you most excited about or challenged about as you look at the broader ecosystem of the US?
Okay, I'm just looking at the broader ecosystem. Well, and I think that word is so beautiful. We have come from a very siloed view of health, and slowly over the years, it's moved from the hospitals and the clinician-patient interaction more to population health. But I think we still have a long way to go, because health is our entire ecosystem, and it comes into play in everything, including our climate. Climate health is health. And so as we go through this evolution, we are going to need to team and come together and partner in ways that we never have before. So we're going to have forums, maybe like this, where we're bringing together all sorts of people in different aspects of the ecosystem for some conversations. And no doubt it's going to require some forming and storming and norming before we're seeing a lot of performing there.
Yeah, that's a great point. And I think, and Q, you mentioned like fragmentation is like the name of the game for American healthcare. And I wish that were not the case, and I have dreams that it weren't the case, but I think it will be for a long time. And I think in the absence that, and in the knowing that, things are going to be fragmented for a long time, what becomes incredibly important are those connectors. So who's going to sort of hold your hand as a patient, like through whatever complex situation you're dealing with, and not necessarily just in healthcare, but also in sort of those like social determinants of health and other related social services. Like, I think it's been really exciting to see over the last, healthcare companies have been trying this for a long time, but there's continued effort and continued innovation, I would say, in different kinds of those coordinator, connector, sort of holder roles. Like they can be care coordinators, care navigators, sometimes they're community health workers, sometimes they're social workers. But I think there's, what I am encouraged by is there's continuing investment in this space, both in like who are these people and what do they do, but also what are the tools that serve them? What are the technologies that they need to be successful? And that's what I think is actually kind of exciting to think about, that even in the midst of this fragmented system, there are still people who whose job and whose priority it is to connect the pieces and to guide people through.
Yeah, maybe I'll say the one negative thing, or maybe controversial. I think until we can reform some of our payment methodologies, we will continue to erode trust, because physicians have to see 60 people a day to be able to, put food on their table, and a 2-minute visit with a patient is not going to build trust. And we have to find ways to be able to compensate them for doing some of the social suggestions or referrals to social services or community health opportunities, which they do not do today because they won't be paid for that. And until that can be better, I don't think it'll ever be resolved. I think we'll continue to see trust erode a little bit, just because we have to, it's more like a machine. I've got to bring all these people through this machine and get them seen, and less about the whole person and really truly understanding what their needs are. Because typically a lot of the reasons people have high blood pressure or others are from social factors, things that are in their personal lives. It's not always a medical condition that's driving some of their behavior. And until we can include all of those things, I think we're going to struggle a little bit for a while. But having said that, I'm super optimistic still that there are so many things that can be done to improve healthcare and to improve the trust. So, it's just something that we have to constantly be thinking about.
And we're calling this the Transformative Health Leaders Program. I represent community health centers. I think what we often learn as clinicians is that what happens in the exam room is so important, but ultimately so much of health is beyond healthcare. It's beyond the exam room. It's the broader social drivers of health. That's often, I use the acronym health, housing, education, access to healthy choices, labor and employment, transportation or translation services, and a broader view of healthcare that's physical, mental, social, purpose, and financial. And so that idea of thinking more broadly, so that trust isn't just about access to drugs, although that is often the ask, but it's about access to this broader vision of health that's much broader than what happens in the exam room is important. So you talked about forming, storming, norming, performing. I am close to mourning because this session is about to end, but the piece I want to end on is this point of, as you look ahead to the future and the future of trust in healthcare from the perspectives you have, let's go in 10, 20 years. What are the things you hope for, and what are the things we need to do, the group in this room, the folks online, the folks who are watching, to get us there? So, future view of trust.
Yeah, I'm super optimistic, but I'm normally that way anyway. I mean, for 20, well, maybe close to 30 years, I've seen the promise of technology, but I think we're finally at a point where technology actually might be able to make a difference instead of being something that I just have to do. If you look at the technologies out there with, generative AI and some of the abilities to use data, yes, there's bias in the data, but until we start learning from it, we won't be able to determine what that bias is. I also think there's a great opportunity to start connecting through technology to more of the community resources that are out there. There are hundreds of community resources that people do not know about. And if technology could serve those up in a way to a clinician as they're interacting with a patient or a caregiver, that would be awesome. And I think technology can absolutely do that and make it more useful and less burdensome to the clinician. Because today it's just something I have to do, where in the future I do believe it'll be something that really brings benefit to the whole process and not just an additive component.
Yeah, I think looking ahead, what's I think is really important and exciting is sort of the continued push into the community and the continued push to try to address social determinants of health, and how technology can really help facilitate both of those in terms of making tools that used to be expensive or things that used to be very hard to do easier to do and more accessible to more people. And whether that's, empowering individuals to better understand and be able to engage with different kinds of behaviors that will help them lead healthier lives, or if it's like raising up a different kind of workforce in the case of community health workers. I think technology has a really pivotal role in doing both of those. And I think the more we can bring health and care into people's communities and make it not just about, like the kind of monolith of like medical care, but more so about the overall picture of what is going to help people lead healthier lives, like the better we will be. And I believe that technology will have a really big role in making that happen.
So I want Teresa's Connecting to All Social Resources button in my HIS. I want Dorothy's Patient Empowerment in Their Community button in my HIS. And I want that HIE Physician Hypertension button. I want to know that when I push that button, the 2,000 pieces of data are going to come to me in a lovely summary that makes it easy for me to quickly consume what's going on and then validate that with the patient in the room. That's what I'm dreaming of.
That's a great dream. We got to make it happen. All right. So I'll close on, one of the words that I used was fragmentation about our health system, but then events like this, initiatives like this, are often about us learning from each other, finding ways to collaborate, seeking to understand, to be understood, and finding ways for partnerships. Ultimately, those partnerships need to be broad. They need to be across the nonprofit, the public, and the private sector. And so from my perspective, the vision, health is local, like our community health centers, 1,487 of them. But the partnerships that we need to have are local, but also national. And so when I, see leaders like the folks on this panel, I get very excited and inspired about the potential of trust in healthcare for now and into the future. So I'm going to mourn, but thank this wonderful panel for their great presentation and contributions.